on stage Dr. Maninder Jaura, MS, MCH urologist and kidney transplant surgeon, Delhi Heart Institute and Multispeciality Hospital Bathinda, to deliver his talk on emphysematous pyelonephritis, surgical perspective.
Good morning, everyone present. I am Dr. Maninder Jaura, and presently I am working as a urologist and kidney transplant surgeon at Delhi Heart Institute and Multispeciality Hospital Bathinda. Today's topic, I have been asked to present a surgical perspective on emphysematous pyelonephritis. We all know this pyelonephritis is more of a medical ailment rather than a surgical ailment, but we will be discussing the conditions in which a physician needs to call a surgeon as soon as possible. That's basically the motive of today's talk. Coming on to the definition of emphysematous, we all know emphysematous means bulle or air. So emphysematous pyelonephritis, although it is rare, but it is a life-threatening. Even in today's scenario, the mortality for patients untreated emphysematous pyelonephritis, it shoots up to 50% in some studies. So it is a life-threatening urological emergency, and it is characterized by acute necrotizing parenchymal and perirenal infection caused by gas-forming uropathogens. That is the catch. It is caused by gas-forming uropathogens. As these terms suggest, it can occur anywhere in the urinary tract. If it is in the kidney, we call it as emphysematous pyelonephritis. If it is inside the collecting system, the renal parenchyma is not involved, it is only into the collecting system, then we call it as pyelitis. Then emphysematous urethritis is when it is involving the urethral walls only in isolation. And emphysematous cystitis is when it involves the urinary bladder wall. The objectives of today's talk is that we'll be discussing about definition, diagnosis, then we'll also discuss about the risk factors, clinical features, pathogenesis, diagnosis, treatment, and these things I have mentioned, but I'll not be discussing about renal pyelonephric abscesses, pyelonephrosis, and XPN or xanthogranulomatous pyelonephritis. We'll be focusing more on the emphysematous pyelonephritis part. Now, a bit of the history. The first case, it was reported in JAMA with the patient with nematuria, and nematuria the patient was passing air bubbles in his urine, and in this term emphysematous pyelonephritis, it was coined in 1962 for the first time. The various studies which were done, they took these symptoms of upper urinary tract with fever, with urine positive cultures, and or pyuria with or without other identified infectious foci. Radiological evidence of gas in the collecting system, renal parenchyma or perinephric or pararenal spaces, and there should not be any fistula between the urinary tract and bowel, which can explain which can be an alternative cause of air in the urinary tract. So if these things are not there, the fistulas are not there, then we assume that it is because of the gas forming bacteria which has caused the infection. Now coming on to the risk factors. The risk factors are most of the patients, almost 96% of the patients who have emphysematous pyelonephritis are diabetes, whether diagnosed or undiagnosed. So, and a large majority, approximately 80%, that comes up to 4/5 of the patients are females, and it is more prevalent on the left kidney for reasons unknown. And urinary tract obstruction is also present concomitantly in 29% of the patients, and 24% of these patients have stones, which may or may not have caused the urinary obstruction. Mean age of these patients are 55 to 60 years of age, and they have poor diabetes controls with HbA1c more than 11. Clinical features, usually patients have features of pyelonephritis, that is fever, flank pain and pyuria. Symptoms can have acute presentation or chronic presentation also. Nausea, vomiting, dyspnea, change in level of consciousness, and signs, shock and rash. Rash is because of it is because of the air which comes into the subcutaneous tissues of the lumbar area, and it shows off in the clinical examination as rash. So patients who have advanced emphysematous, neglected emphysematous pyelonephritis can present with rash also, along with all these features. Isolated rashes are not commonly seen. Coming on to the clinical features, we can all understand that leukocytosis and thrombocytopenia also in half of the patients they have thrombocytopenia. Leukocytosis is present in almost all the patients. Urine analysis will show pyuria, and hematuria is also there in 13% of the patients. Severe proteinuria is present in 21% of the patients. Now the pathogenesis, all bacteria are the culprits. E. coli is the most common bacteria causing emphysematous pyelonephritis in 67% of the cases. Klebsiella is the culprit in another 20%, and miscellaneous bacteria like Proteus and Pseudomonas are culprits in the 10% of the patients. Some patients, the urine culture reports, they show that there was a polymicrobial infections also, including Streptococcus and Staphylococcus aureus. Then bacteroids and superinfections with Candida are also seen. What is the pathogenesis of these emphysematous pyelonephritis? It is because of the high tissue levels of glucose, as all the patients are who have uncontrolled diabetes. And there is the presence of glucose fermenting bacteria we discussed in the previous slide, and because of that there is impaired vascular supply and decreased tissue perfusion, which causes impaired host immunity, and obstruction of the urinary tract contributes to these things, which leads to this florid emphysematous pyelonephritis. Host factors for emphysematous pyelonephritis is poor glycemic control, and some people they also give history of lower urinary tract instrumentation also, which causes infections leading on to emphysematous pyelonephritis. Pathology: patients who undergo nephrectomies in desperate conditions, who need the specimens, they reveal multiple abscesses filled with purulent exudates, as we can see. There are cavities. If I can. Cut specimen with parenchymal abscesses which are filled with pus, which are seen in the specimens. Now, clinically, coming into clinical perspective or the clinical aspect, when should we think of emphysematous pyelonephritis? A patient who is diabetic, females, patients who have signs of urinary tract presenting with fever, flank pain, chills and rigors, sepsis, patients who have poor glycemic controls, patients who have kidney injuries, whether they are acute or chronic, poor response to antibiotics, patients who do not respond to first line or second line antibiotics in 48 hours, we should suspect emphysematous pyelonephritis, especially in diabetic females. Now, what are the differential diagnosis of gas in urinary tract? I have been talking about it's by gas forming bacteria. There is presence of gas in the kidney. What all conditions can cause this gas in the urinary tract? Slides are not being displayed. Okay. One is instrumentation of the urinary tract, whether because of iatrogenic injuries, incidental or catheter insertions. Then surgeries, cystoscopies, transurethral tumor resections. Then patients who have had ileal conduits for carcinoma, urinary bladder, or for any other reason for supplementation of ureter, and then post-ureter sigmoidostomy for after radical cystectomies. Then fistulous connection with hollow vesicles like gut, like vesicovaginal fistulas. Then penetrating trauma or blunt trauma. These all also can cause gas in the urinary tract. So basically we have to rule out these causes before labeling the patient as having emphysema pyelonephritis. Now we can see there is a air bubble in the renal parenchyma. So this is a plain film of KUB. Now this is a cross section of the CT. This is a cross section of the CT scan showing. Coming on to the diagnosis part, on plain films we can see a collection of gas. I'll be showing it in this thing. As we can see, there's only on plain. It's not. It's there. We can see that there is gas in the. Excuse me. उसका व्यू चेंज करके उसको सेंटर में नहीं आ सकता. It could be in the renal parenchyma also. So ultrasound is usually the first line modality that we apply for diagnosis of pyelonephritis, and it can give you idea that yes, it could be emphysema pyelonephritis. And the limitations of ultrasound is that it is limited by body habitus, especially in patients who are obese, morbidly obese. The window for renal windows are not sometimes available, and obviously it is less sensitive than CT. Now CT scan is the gold standard investigation for diagnosis of emphysema pyelonephritis. In patients who have preserved renal functions, will like to get contrast enhanced CT scan. In patients who don't have preserved renal functions, whose creatinines are high, we definitely go for non-contrast CTs. Even non-contrast CTs can give you an idea where the air is in the renal parenchyma, how much loss of renal parenchyma has already been done, and it is definitely the preferred modality. It assesses the extent of involvement. IV contrast can provide information about function, definitely yes. 100% sensitive in the larger systematic reviews. Now this is an image where we can see that the right-sided kidney, almost half of the parenchyma has been replaced by gas. Now classification, why we need to classify this emphysema pyelonephritis. As you can see the figures on the extreme right side of this thing, these are the mortalities. Patients who have class 4 emphysema pyelonephritis, it's almost 50% mortal for the patients. So we need to classify on the initial imaging that my patient is in which category and how aggressive I need to be in these patients. So a class 1 emphysema pyelonephritis is that the gas is only in the collecting system, or it is only a pyelitis. And class 2 is the gas is in the renal parenchyma. Class 3A is that the gas has extended on from the renal parenchyma into the perinephric space. Whether it's a perinephric space, is a perinephric fat, or anteriorly into the peritoneum. Then class 3B is gas is in the pararenal space, it has gone beyond the Girota's fissure. So 3A and 3B are similar almost, but the mortality figures are different. If it is limited to perinephric space, it's 20. Class 4 is if emphysematous pyelonephritis is involving both the kidneys or a single kidney in a patient who already has lost one kidney. This is the figure. In this, we can see the arrow marked. It shows that the air is only in the pelviculation system or the pelvis of the right side kidney. So this is the class 1. Class 2, we can see the kidney parenchyma has been involved. The gas has occupied the. In class 3A, there is a perinephric space. The arrow is marked there. It's extending from the renal parenchyma into the perinephric space. Then class B is pararenal involvement. As we can see, it has gone anteriorly also. Posteriorly also, Girota's fascia has been breached and it has gone into the almost till the parietal wall. This is class 4 as both the kidneys have been involved. So this is the class 4 emphysematous pyelonephritis. Treatment mortality. Treatment and mortality ranges from 11 to 42%. Even this was a meta-analysis which was done in 2007, and which all patients have higher mortality. We can screen out those patients who keep on undergoing conservative managements, patients who have bilateral emphysematous pyelonephritis, patients who have thrombocytopenia at presentation, patients whose systolic BP is less than 90 mm mercury at presentation, and patients whose initial creatinine levels at presentation are more than 2.5 mg per deciliter. Patients who have altered sensoriums at presentation. So these patients have poor prognosis. We should be alert from the very first minute. Now treatment basics. Obviously a patient who is unconscious, who's in shock, has to be admitted. ICU admission, we can always decide whether he needs an ICU admission or not, depending on the initial vital screening of the patient. Fluid and electrolyte correction is to be done. Appropriate antimicrobials. We'll talk about these microbials, antimicrobials, which all antimicrobials, antibiotics we have to use. Then treatment of diabetes is the first and most important thing which has to be done, because it is the most important cause leading to this pathogenesis of emphysematous pyelonephritis. Blood sugars have to be strictly under control, whether with oral hypoglycemic agents or we need to use insulin. Then after the diagnosis, after the initial investigations, we need to relieve obstruction of the affected kidney if it is already there. If it is there because of the stones, because of necrosed papillae, because of any malignancies, it has to be relieved. Then we have, in cases of unilateral disease, we have to establish function of the other kidney. This is important because in desperate conditions, we may need to do a nephrectomy in a patient who is not responding to conservative management. So the function of the other kidney is of paramount importance, and we need to counsel the patient pre-hand whether he will be on a maintenance dialysis after that or his other kidney is functioning well. Then antimicrobials. These are the Canadian guidelines which they have reported high rates of clinical and microbiological cure. But they recommend using aminoglycosides, fluoroquinolones, piperacillin, tazobactam, ceftazidime, carbapenems. At least 14 days of antimicrobial therapy is necessary in a patient who has a diagnosed emphysematous pyelonephritis. In our clinical practice, our first line of antibiotic is piperacillin, tazobactam, which we use 8 hourly. And in patients who do not respond to piperacillin, tazobactam, we switch over to meropenem. By the time we need to switch over, the culture reports are already there, and we can have culture specific antibiotic which can be used. This I have already talked about. Yes, if the patient already has some kind of a stent, DJ stents, Foley's in situ, they have to be replaced immediately, and their tips to be sent for urine for culture, so that to guide us in the further antibiotic course. Then there comes in which all patients we need surgical treatment in emphysematous pyelonephritis. In patients who have obstructions of the pelvic calcium system like stones, malignancies, necrosed papillas. In these patients, we can do internal drainage in the form of degestanting, or external drainage in patients who are not fit enough to be shifted to OT. We can do bedside percutaneous nephrostomies also. These are done under ultrasound guidance and they are minimally invasive and life-saving procedures. Percutaneous or open drainage of the collections in patients who have class 3 or 3A or 3B emphysematous pyelonephritis, in which the collections are outside the renal parenchyma, involving the perirenal or the pararenal spaces. We may need to put in drains, percutaneous drains under ultrasound guidance to take out those pus and gas, or if it is not feasible, not available, then we'll have to do an open drainage of the abscess. In patients who do not respond to these conservative or relatively conservative modalities, they may need desperate emergency nephrectomy or a planned nephrectomy in patients who have total loss of renal parenchyma. Now, this Somani and his colleagues, they did a systematic review in 2008, and they came out with these figures that in patients who have emphysematous pyelonephritis, if only medical management is done, there's 50% chances that we'll lose the patient in due course of time. And 25% patients in which medical management and emergency nephrectomy was done, they also had 25% mortality. Patients who needed only medical management with percutaneous drainage, the mortality came to around 13%, and patients who had medical management with percutaneous drainage and later on elective nephrectomy was done, obviously because these patients were stable enough to go for elective nephrectomy, the mortality rate was only 6.6%. So a conclusion is that fluid resuscitation, aggressive antibiotics, correction of the precipitating factors like obstruction, and early percutaneous drainage with or without elective nephrectomy when indicated gives best outcomes. Complications of emphysematous pyelonephritis, we all know that sepsis, death, and failure to respond to medical treatment, then relapse. Some patients did come back with the recurrent emphysematous pyelonephritis. The infection can extend to the adjoining organs, lungs, bones, vessels, liver, spleen, and skin, causing infections of those organs. Now, this is my last slide before I conclude my talk. Take-home messages: be suspicious in patients who are diabetic and who are females, who present with fever, flank pain, and chills and rigors. Patients who rapidly deteriorate in spite of starting broad spectrum intravenous antibiotics. In these patients, please suspect complicated pyelonephritis, which may need surgical intervention. Thank you. Sorry, sir, I think you need a mic.
Thank you, sir, for the talk.
Thank you, Dr. Jaura. First of all, we welcome Dr. G.S. Wander, Chief Advisor, CC. And since we are short of time, you see, the only one thing I think the carry-home message is diabetes and pyelonephritis is very, very common. And anybody you see who is having a resistant sort of pyelonephritis, not responding to conventional treatment, probably should be subjected to further investigation to rule out emphysematous pyelonephritis. That is I think my carry-home message for today. Thank you very much. Thank you.
Thank you.